I'm Valeria from Radiology and standing in for Dr. Ugez. So, okay, so I'll take you through the imaging, and phaeochromocytoma is a clinical diagnosis. So we in radiology prefer you give us the history before we do the imaging. So just like they've said, the triad of presentation and the laboratory tests that are needed. So what's the role of radiology in phaeochromocytoma? We want to locate the tumor after you've given us the clinical diagnosis. Where is it located? 90% adrenal glands and 98% in the abdomen. The extra adrenocytes take up the 10%, and that's the organ of Zucker-Kandel at the level of the inferior mesenteric artery, the sympathetic chain, so we look along the aorta. Yes, the mediastinum. I want to look at the urinary bladder as well for extra adrenal sites. So someone mentioned in pediatrics you have a small mass. What do you do about it? We can follow up in radiology. We want to see how is it rapidly increasing in size. We look out for signs of malignancy. Is it invading adjacent structures? So we tell you now is the time to work on the patient. Screening in men 2 and men 2A, we want to locate where the other masses are. The thyroid gland, parathyroid, pituitary tumors. So we can, that's radiology as well. So what can we do? We do abdominal ultrasound scan. And in the pediatric setting, because of the fear of radiation, this is the modality of choice. And in our setting, many of our centers don't have CT scans and they don't have MRI. You can locate big masses using ultrasound. CT, if we can access it, just like we do in Mulago, is the modality of choice. We have to be prudent enough to scan our patients right from the diaphragm to the pelvis if we are looking for the abdominal paragangliomas. MRI, if you miss the mass at CT, MRI with its high resolution, we are able to locate the masses as well. Nuclear medicine, radionuclide imaging with MIBG, like it has been said, it's very specific for phaeochromocytoma with a specificity of about 98 to 100%, according to the recent literature. We do bone scans as well for metastasis or for metastatic disease. We can still do positron emission tomography scans with FDG to locate malignant uptake in the tumors. Venous blood sampling, like it was said, you can look at the plasma catecholamines and so on. And we can also do biopsies, but very, 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 very rarely and probably not so much indicated. So that's an ultrasound scan. So the image to the left is a transverse image, and this is a sagittal image. So we are able to see the liver, the right kidney, and that echogenic or hyperechoic retroperitoneal mass. Retroperitoneal organ is the adrenal. And in transverse, you can see it posterior to the inferior vena cava. So our first patient who was presented was a 25-year-old female with a left suprarenal mass. So when you do an ultrasound, you see this well circumscribed hyperechoic mass, though with areas of anechoic, which would be echo complex. And we see it's also vascular, relatively highly vascularized, but well circumscribed lesion or mass. Again, when we did a coronal oblique scan, we see that round, well circumscribed mass in the left adrenal. So in this patient, at that point in time, we are able to say you have a left suprarenal mass, but without the biochemical or the presentation of the patient, you are only able to say it's a left suprarenal mass, and you're left saying, is it an adenoma, is it a phaeochromocytoma, is it an adenocarcinoma? But with the history, you profoundly say, I think this is a phaeochromocytoma. So at CT, we are able to see those retroperitoneal adrenal organs, very small in size. They usually have a shape, an inverted V shape. So that's the right adrenal, and that's the left adrenal gland, normally at CT. So the same patient had a CT scan done, pre-contrast, then they did a post and a delayed phase. So to the right is a well circumscribed heterodense mass. You see it has that central area of hypodense or central area of necrosis, and then it has the solid area in the left suprarenal area. So this is a contrasted image. Why do I say contrast? We see the vessels standing out and bright, and then the kidneys taking up contrast. So we see it still has that central area of hypodense, and then the surrounding solid area, which highly takes up contrast. So we see pre, it was about 7 to 23 Hansfield units, and post 25 to 89. The central area is necrosis. The non-necrotic area takes up contrast highly. And this is very, very typical for phaeochromocytomas. That's how big it measured, but seemingly it was bigger at surgery. But here it was about 5 by 5 centimeters. This is a coronal image as well, showing us the mass. Here I wanted to show the surgeons normally want us to tell them the inversion of organs. The left renal vein is normal, and this is not a thrombus in the IVC, it's just the phase and the mixing of blood at that point. But this mass, seemingly, to me was invading, showed some peri-fat stranding of the fat adjacent to the mass. But however, the renal vein, the aorta, and the IVC didn't show any thrombus. So in the delayed phase, we see the mass loses contrast. We call it washout. So when you take the density of the solid area, it washed out up to 60 Hansfield units, which is important in differentiating adenomas and phaeochromocytomas. You can calculate the relative washout and the absolute washout. So in conclusion, that's what we had: well circumscribed mass, significant enhancement, perilesional fat stranding, other organs were normal, and we had no lymph nodes or ascites. But for this first patient, my thinking was, could it be malignant because of that fat stranding, though not evading the vascular structures? So there was room for other modalities. Like MRI, it would really give us that extent of the mass to show us whether it is invading the other structures or not. And then the radionuclide imaging. The second patient who was presented was a 36-year-old male with the right suprarenal mass. So this is the liver, and this is our mass with a central hypoechoic area, which is an area of necrosis, very common with phaeochromocytomas, and then the solid component. We still see the mass is relatively vascular on spectral Doppler. The same mass, it's just ultrasound gets beautiful when you start doing it and seeing things. This was just to show us the kidneys that were normal and not invaded by the tumor. So it appeared the same as the other mass, though here we have more necrosis at ultrasound that we see, but a phaeochromocytoma taken in picture with the history and presentation of the patient and the laboratory workup is the diagnosis at ultrasound. This patient as well had a CT scan done, and this is an axial contrasted CT scan image, and we see that relatively ill-defined mass, because I cannot easily tell its margins, but with a central area of necrosis and a solid area that highly takes up contrast. The same mass on the left right suprarenal area, and this is a coronal image as well. These are images just show us that other organs were normal. These are the kidneys ably taking up contrast, the pancreatic head, the aorta, and then we see the gallbladder and the liver at that level. So still, same mass, well circumscribed, heterodense with areas of necrosis and solid areas significantly and ably taking up contrast. Other organs were normal, and taking into account the history and the presentation of the patients, a phaeochromocytoma is the diagnosis. But like we said, we don't talk about phaeochromocytoma alone, but the paragangliomas, and we can ably image them at ultrasound, MRI, and CT. Thank you very much.